So I'm going to talk about a big project that I've been working on now for the last 5 years with Kona Medical. There's a lot of different components. There's basic science, there's animal work, there's simulations, there's a lot of clinical work going on. I'm going to focus on our commercial system that has just reached CE mark in the last couple weeks, and also will be also has been approved for an IDE by FDA. So it's a non-invasive, ultrasound-based imaging and therapeutic system for treating resistant hypertension. We heard about a model before. So this is an image guided by ultrasound, but it is therapeutic ultrasound as well. We've treated over 150 patients now. There's 3 pilot studies, Wave 1, Wave 2, Wave 3. They've been presented several times here and in other forums. We have a randomized sham-controlled study, Wave 4, which is ongoing now in several European centers. That will be discussed in some upcoming cardiology meetings. And I'm going to talk about the commercial system, which has been under development for the last 2 years and is just about ready for CE mark any day now. Hypertension doesn't really need an introduction. There's over 1 billion people worldwide with hypertension. The majority of them are either uncontrolled or non-compliant with medications. In either case, it is the #1 factor in global deaths due to blood pressure being uncontrolled. So why do we do this external? We saw a nice presentation before. You can treat much smaller blood vessels than you can with an internal catheter, which has traditionally been the way it's been done. You can see here on the right the location of the nerves. This is from cadaver models. The location of the nerves in the distal part of the renal artery, so close to the kidney. And then you can see the position of the nerves more proximal to the aorta. It used to be thought that you had to treat the more proximal nerves near the aorta. Now it's more distal towards the kidney. You can see the nerves are closer to the artery. The artery is also a lot smaller. So external ultrasound is probably a better way to treat these smaller blood vessels, which are likely the more relevant ones for renal denervation of the kidney. Also, you can see the differing patterns of the nerves. And the thing is, with basically software control, we can control any of the size of the lesions and the overall pattern. The other big advantage here with external as opposed to internal with a catheter is that the treatments can be repeated. So maybe it's not the best way to do a one-time treatment. Maybe it's multiple treatments. We heard that with some of the other technologies earlier, that repeated treatments seem to be more efficacious with external ultrasound as opposed to an internal catheter. We can actually repeat treatments, and we've done that in animals now and in humans. So in the product development pathway, it's been there's a lot of complication in doing this. What we've developed is a self-contained system to only treat the renal nerve. So its only function is to ablate these renal nerves. So everything's been focused on that, and we can really optimize how we do the treatment. There's obviously all the other parameters in any focused ultrasound system that need to be optimized. So there's what's the dose, what's the therapeutic treatment. It's got to fit into sort of clinical parameters. It's got to it's got to fit into the workflow of a doctor, of a patient. With the renal nerves, because the kidney is moving with every breath, there's tracking that's involved. And then how do you maintain the target? And what is the target? Usability is very important in any commercial device for a physician. It's got to be usable. They have to be trained quickly with maybe 5 or 10 procedures. You want them to be facile with the system. There's a lot of regulatory issues. FDA's been great. We've been working with them very closely on this. And then there's the clinical trials. Here is the system here. You can see all the way to the right, 2016. That's the system that I'm going to show you right now. And I'm going to skip this slide so that we can, this is just some of the simulation that we've done. We don't do real-time simulation. In other words, we don't do per patient simulation. We've taken an average of about 70 scans to get a pattern that's essentially an average for every patient. I'll show you our video here, which sums up nicely. It's a self-contained system. You can see that it's on the right-hand side. You can see the imaging transducer. It's separated from the therapy transducer. Okay, they're completely uncoupled. They are coupled in space by an optical coupling system that we developed. There's tracking of the artery, which was on the left. It'll loop around again. And here's the pattern that we create. Again, simulations with 70 CT scans initially to determine the optimal pattern. Okay, you can see the tracking here on the left side of the video. We're tracking, we target the bifurcation. Right now we're targeting the bifurcation of the renal artery. We're tracking during the entire treatment. It takes about 2.5 minutes per side. That's the power on time. And it's about, we're doing the entire procedure in about 45 minutes. There's some setup time for each side, locating the artery, et cetera. Okay, I think I can take some questions from there.
Thank you very much. Question in the audience? Yes, Vladi, please.
You look as though you're delivering energy and sonications across the full width of the renal artery. Why aren't you damaging the media and the muscular components of the artery?
Yeah, so the blood flow is the main reason that happens. Is that the blood flow is taking away the heat from the arterial wall, and so there's no damage inside the
Why doesn't that apply to the nerves then?
Excuse me?
Why doesn't that same criteria apply to the nerves then?
The nerves have a lower threshold for damage, and this is something that we learned earlier, that you can see nerve damage without seeing any other tissue damage in the area. When we do our dose response, our toxicity studies, if we go high enough dose, we can start to see medial damage to the artery, medial and intimal damage on the artery, and really gross nerve damage. But at lower doses, we don't see that on the artery. And I'll just say that even at the highest doses that we deliver, to try to see artery damage, we don't see anything near what is seen with an RF catheter, radio frequency catheter, that's actually touching the internal part of the artery and damaging it. And so,
and the potential of you're going to be dealing with diseased renal arteries, which are thickened and abnormal with atheroma, etc. Do you think that will change the possibility of significant stenosis as well?
Well, I'm sure it changes the possibility, and again, if you look at the invasive catheters, there is a stenosis rate with their procedures, 1%, 2%, 3%. It's probably underreported. In our 150 patients, we have not had any stenoses at all, no damage to the artery long term. And in the follow-ups that we've done MRI, we've done Doppler ultrasound, and in the animals, even at the highest doses, we didn't see any significant stenoses after 6 months or so.
Okay, so it's time to close our session. Maybe on the stadium, on the stands.
Any possibility of
Maybe,
regrowth of the nerve?
I'm sorry.
What are the possibilities of regrowth of the nerve or the vessel?
Yeah, there is regrowth of the nerve. There's a lot of studies in the past looking at kidney transplant patients, because obviously you're reconnecting arteries, renal arteries, and there's definitely regrowth of the nerves. The question is, they probably don't regrow to the same extent, and they don't make the same connections, and so longer term they don't function the same way. But there is definitely regrowth of nerves.